Greetings, I'm John White, a psychiatric resident at the University of Arizona in Tucson, and I'm here to present our group's research project on forging resilience in residency. As you can see here on the screen, our poster is up there, and I'm going to go through the individual parts of this poster, describing why we thought this was important, what we did, how we did it, and what the results of that were. So this project was completed by myself, Dr. Jennifer Bao, Dr. Michael Duerden, and we had assistance from our faculty supervisor, Dr. Michael Colon. You can see our three fine researchers here participating in a wellness event, and above that is our summative statement. And when we were researching this idea of burnout and resilience, we found that burnout's pretty relevant to medical training and psychiatric training. So we sought to design a pilot lecture to assess efficacy of worksite resilience education. Following the delivery of this lecture, there was a positive impact to participants' understanding of resilience, indicating possible future directions for resilience training in residency. So why does this matter? What am I saying? I think it's worthwhile to define a few terms so we can kind of all be on common ground. Resilience is the ability to maintain or regain mental health despite experiencing adversity. So this is the idea that you can thrive rather than just survive in an adverse situation. And that leads to the other part of this, which is burnout. What is burnout? It's thrown around everywhere now, but really it's commonly understood as emotional exhaustion, depersonalization, and decreased personal accomplishment. Now, burnout is qualitatively different from depression because it occurs and is related to the work environment. And if you don't address burnout, it can lead to disrupted work, reduced productivity, and decreased job satisfaction, and several others, obviously. So this gets us to why resilience is important. So with stress, burnout, job strain being prevalent in our workspace, it can really have a large impact on physicians. And if you don't build resilience, it can lead to a lower quality of life, negative lifestyle factors, and general job dissatisfaction. So that's why we think it's important. And then we took that information and synthesized that to help discuss with residents in our intervention, which is this next part, our middle poster, the middle portion of the poster. So we discussed with the residents in our intervention that burnout does impact medical training. In residents, medical and surgical, up to 80% of them experience burnout. Now, in psychiatric residents, it's a little bit lower, 33.7%, but it's still there and it's important. So things that can continue to propagate burnout would be the perceived stigma of seeking help, workplace and learning culture environments that foster this inability to seek help and continue doing what you're doing. So what can we do to prevent this or help stifle it at least? How do we build resilience into residency training? Well, I think it's first important to recognize the way that you think or cope. And if you can change that, then you can also improve resilience. So there's this idea down here on the lower left of a control-oriented coping style. What that is you're not controlling your whole environment, but you cope through finding a nidus of control or an internal locus of control, which gives you the ability to accomplish goals and be fulfilled. And then that gets us into how resilience fits into residency training. So this framework was developed by Berger and others, and I think it is a nice way to conceptualize this. So there are three paths: wellness, resilience, and burnout. I'm not going to go on burnout because we touched on that, but wellness I think is worthwhile to touch on first because it's been a focus of residency programs in the last several years, and it's important. So every individual has this unique set of baseline attributes, and they chug along going through training, but then all of a sudden they experience a negative workplace environment or an adversity. And then what happens? Well, you engage in wellness. You take your available resources, social supports, engage in leisure activities, and then you can cope. You retain wellness outside of the workplace, but it doesn't improve your ability to engage in that difficult moment or that difficult workplace situation. So this can lead to less personal investment in clinical encounters, leading to suboptimal residency training experiences. So if we rewind and go to the resilience pathway, negative workplace event or workplace adversity, in the resilience pathway, you begin to engage with it. You look at the event, you reflect on the event, you look at the challenging components of it. And as you're doing that, you begin to recognize the opportunity to create change, to recover. There are a few ways to do that. One is through seeking help. That's formal, informal, mentors, peer supports, that kind of thing. That can help you facilitate change. But as you facilitate that change and recover, you actually enhance an individual's baseline attributes. So they can take that baseline attribute and reintegrate it into the routine aspects of residency training. And then when they hit a new workplace adversity, it's less likely to cause a large impact. So improving baseline attributes is the focus, and wellness improves an individual's ability to maintain balance within their life. It does not likely improve the baseline attributes. So that's why we want to focus on resilience in residency training. So how do we foster resilience within a program? Well, we want to keep to the prime directive, engage with the event, and reflect on the challenging components of it. Recognize the opportunity to create change. Now, you can't do this if you don't know yourself. You need to be able to recognize thinking traps, cognitive distortions, coping strategies, and then challenge those. Know when to change them. And this can be done through formal and informal feedback, but it's worthwhile to look at, am I thinking about this the correct way, or can I change my view or the lens to help foster resilience? Other ways include physical connectedness, biofeedback, emotional connectedness like process groups, and mindfulness. Moving on here to the bottom portion of our poster, this is something that we did with the residents in our interventions. What can I do today? What can I actually do to improve my own resilience? So we did this exercise with them. It's pretty simple. It's based on the ability to reflect and recognize what's important and how it affects you. So you start with a question and you go backwards through your day until you find the first answer that comes to your mind and you write it down. Then you process, you repeat that process for all 3 questions and you continue that daily. And it's important to recognize here that it's not the concrete answer. So even if it's nothing, that's okay. It's the act of conceptualizing your day and looking at what surprised me, what inspired me, etc. We're going to move on over towards the results and discussion section. But before we dive into that, I want to talk about how we did what we did, meaning our methods. So psychiatric residents were given a 4-question pre-lecture survey to gauge interest and knowledge of resilience and resilience training. This same cohort of residents were then given a lecture by a group of their peers, i.e. us, the researchers, designed to educate, emphasize, and build resilience skills. Then the same pre-lecture survey with 2 questions added for our own interest was again sent out to post after the lecture was sent out to the same cohort of residents to gauge the cohort's viewpoint changes on resilience education and training. Then a one-tailed paired t-test was used to compare the mean values of responses to the pre and post lecture questions, specifically 2 through 4. 1 was basically you knew it or you didn't, and 5 and 6 weren't given in the original one. So that gets us to our results. Pre-lecture data indicated that the cohort of psychiatric residents were able to accurately gauge what resilience is, but acknowledged a lack of comfort in identifying qualities of resilience. Our t-test displayed a value of 0.18, which is not significant, but does show that a slight improvement in ability to understand these concepts. So in our post-lecture data, we did have few responses, 22 instead of 36, but this indicated an improved comfort in identifying qualities of resiliency. So it was 91% instead of 51% of somewhat comfortable. So what does this all mean? How can we conceptualize this? Based on the differences between pre and post lecture responses, residents would likely benefit from more dedicated resilience training and exposure. There are limits to what we did, lack of statistical significance, power, a single encounter, those kind of things. So future directions would include a more in-depth and targeted curriculum over multiple encounters. That was brief. I appreciate your time and the ability to present this poster, and I look forward to the Q&A session. Thank you.